the Board of Health meeting for Monday, June 9th. We could stand and say the Pledge of Allegiance. I pledge allegiance to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all. Alrighty, so thank you, Lee and Aaron, for joining us via Zoom. So we are, first on the agenda is approving the Board of Health minutes from May 20th, 2025. Did anyone have any corrections or adjustments to those minutes? The motion to approve?
Move to approve.
Second?
Second.
Excellent. So next, no current organizational issues, important health dates. Actually, I forgot my paper that I had. So, of course, I think most of us know June is Pride Month. So there's extra programs regarding LGBTQ health issues available in the community. It's also Men's Health Month, and this week specifically is Men's Health Week. And usually this is an opportunity to discuss or bring up in public testicular cancer screening, prostate cancer screening, et cetera. Dave, next that brings us to the communicable disease update.
Thank you, and thanks for your forbearance in me bending your ear month after month. On the major respiratory illnesses, there is nothing I have to report. I have a COVID discussion I want to bring up at the end of my comments. The measles outbreak here has gone from an exponential phase to a linear phase, but that linear phase is that every 2 weeks there are more cases this year than there were in the entire year last year, which was more than twice as many cases as there were the year before. If you are planning to travel, the hotbed areas are Texas and New Mexico, but the U.S. is behind Germany and UK in terms of the Western world. So if you're getting on airplanes and getting in airports, you have a significant risk of exposure to a virus that is hideously effective at transmitting itself. And if you are not protected either by natural immunity, which I am by dint of my particular age, or by inoculation, my strongest advice is that you get the inoculum because it's really not a benign issue. And if you're traveling with your kids especially, I would recommend that, which also raises, as pointed out last time, if you're traveling, take advantage of travel services because there is lots and lots of stuff going on around the globe. There are excellent travel health facilities, Penn Medicine right here in Radnor, and also elsewhere in the Delaware County and the Delaware Valley in general. With regard to the topic raised 2 months ago and covered off on by me last time, the avian flu, there's really not a lot to report. That's really become pandemic among mammals and avian species. It's out there. It's hard to keep track of because many places aren't reporting. But the important thing that happened since our last meeting was that our new director of the NIH shut down the development of an avian flu vaccine, which I think is a huge mistake, and I hope we don't pay for it, but we just don't know in that regard. The first outbreak of foodborne salmonella for the season has been launched. Keep an eye on that. The Lyme disease cases are ticking up. Be careful for arthropod-borne vector diseases. They can hurt you. And in fact, let me take a minute to ask Babby to share her own story today in that regard.
Yes, about an hour ago, and I was on my porch and getting some running shoes out of a basket. I was stung twice by 2 different yellow jackets. Sadly, I'm sure they lost their life, but I just wanted to remind people to, in the summer months, have things like antihistamines or class 2 antihistamines in the house in case needed.
The risk is there and will be increasing as the weather actually warms. The last thing that I wanted to bring up was, with regard to COVID, there is a pretty significant kerfuffle going on among the traditional powers that be at FDA, NIH, CDC, and the new administration over, some of it is over, it's predominantly over approvals, which makes it rather recommendations, which makes it a financial issue and not a science issue. But my own personal opinion expressed last time was, it's hard to know. I don't think that there can be good public health recommendations because there is so much individuality in the circumstances that everybody finds themselves. But the availability of these vaccines for those who feel they need it, I think it's important, and we'll see how that goes. But the reason I wanted to bring up COVID at all this go-round is that a study was published since our last meeting in JAMA Pediatrics, in which they investigated let me find the right spot in the notes. They investigated the incidence of long COVID in over 1,000 children. They found that 14% of infected infants and toddlers and 15% of infected preschoolers had a probable long COVID syndrome. So we kind of made the assumption that long COVID belonged to old folks like me. That's probably not true. We probably came to the conclusion that long COVID was not a risk for our children, and it may well be. So for infants and toddlers, the most strongly associated and prolonged symptoms were poor appetite, trouble sleeping, wet and dry cough, and stuffy nose. And in pre-age children, daytime tiredness, dry cough were predominant. Teens and school-age children were more likely to have memory trouble, lightheadedness, and other neurologic issues, including post-exertional malaise. It was a well-done study. 1,186 children under the age of 6, 670 of them who had tested positive, 516 control children, and they were followed for the length of the study. And on average, infants and toddlers had symptoms that lingered for 10 months and nearly 17 months in preschool age children. So the notion that we can just discard the thought that young people should be vaccinated for COVID needs to be taken in a slightly different light than the information that I had before that, which is, oh, it's just a cold. And the title of the article is, COVID may not be just another cold. So that's all I got for you. Thank you for your kind attention.
Could I add two quick things? One is there's been an uptick in pertussis as well, no surprise, following the measles uptick. And the other thing is we have a new tick. We have the Asian longhorn tick has been found in Bucks County. And it can be on lawns. It swarms. I mean, it sounds like a nightmare. There was a woman in Bucks County that stepped into a grassy area and got over 100 ticks on her. Yeah. And it carries different diseases than what we're used to. There's some rickettsial stuff. There are other Asian diseases that I wasn't terribly familiar with. So it's not the usual Lyme and even Rocky Mountain spotted fever for the regular wood ticks or anaplesia. It's not the regular stuff. So. But
thanks as always for the excellent additions, and it does carry febrile-based illnesses, and the pertussis. I mean, if measles is going crazy, it's because of the lack of inoculations, and it's going to be measles, mumps, rubella, pertussis. All of them are going to appear.
Something that I was going to include in the my report for Delaware County, I'm going to talk about now because, like I said, I forgot my papers, and since I'm remembering it right now, I want to report it. So they meet every other month, and so this week is their meeting for June. So there really wasn't any new information posted from March, but I was able to take a look at some of the presentations, and each meeting they have basically a report on communicable diseases in Delaware County. And I wanted to bring this up since we're talking about measles. We've discussed as a group that 95% is where we want immunization rates to be for protective of the entire community for measles. And they had a chart that was from data from 2023 of kindergartners in the southeastern part of the state. And Delaware County was just slightly below 95%. It was above. It was a chart, so I couldn't tell exactly what the number, but it was above 94%, but definitely below 95%. Other counties in our area were just slightly above the 95% or right at the 95%. So something to think about, and I'll continue to kind of keep an eye on those, what their presentations at the county, because they were very detailed, a lot of time put into them. Any other comments regarding communicable diseases? All right, so I guess that brings the meeting to me. Let me just change location. Okay, great. Alrighty, so I wanted to share a little bit, because I know it's a very popular topic right now in community and in medicine, a little bit about GLP-1 agonists for weight loss. Now, this could be a 4-hour talk, and it could be very clinical based, because obviously some of us are clinical providers, but I also kind of wanted it to be somewhat community informing as well. So in some cases, I'm citing specific things, and in others, I'm just kind of talking about clinical experience. Once again, I'm an endocrinologist, so I became familiar with these agents first for use in diabetes, but now they're being used for weight loss, and I do have a number of patients who are on these medications for weight loss as well. All right, so the ones that are out in the ether that people have heard about, the brand names Zepbound, Wegovy, and Saxenda. Right. So first GLP-1 agonist to market was Byetta. So this was actually right before I started fellowship. It was the new excitement in diabetes. Byetta is no longer available because we have other agents. The Byetta was quickly followed by Victoza, which is liraglutide, Bydureon, which is the long formulation of Byetta, exenatide, Trulicity, dulaglutide, and then Ozempic, which I think is the one everybody's heard the most about, which is semaglutide. So Byetta actually, when it came out, was twice daily. It was a twice daily medication. Victoza is a once daily medication, and then Bydureon, Trulicity, and Ozempic are once weekly. I say were, but they are once weekly. They're all injections, and all of these medications are approved for type 2 diabetes. And so what they found as they were studying these agents is that it resulted in weight loss in a lot of patients. And so because of that, it started being used off-label by physicians for weight loss, which is actually a pretty common thing that occurs. If physicians are seeing an agent working well, they can use it off-label with appropriate discussion with patients. And then subsequently, because of the weight loss, it was studied by the companies for potential use as a weight loss medication. I will say that not every diabetic loses weight on these agents. I have patients who are like, what the heck? My sister-in-law went on Ozempic and she lost 30 pounds. I've been on Ozempic for 5 years. How come I haven't lost any weight? And it is very specific. Not everybody loses weight on these agents, especially diabetics. But they are usually very good for improving blood sugars, which actually in diabetic care is the most important thing to assist with. So how they work, they stimulate the GLP-1 receptor, and GLP-1 is a hormone which is made by the small intestine, and it influences receptors that are located throughout the body. So most relevant to this discussion is that they're present in the pancreas, the brain, and the stomach, although they are finding them in many other locations in the body, and they're, it's leading to more research ideas about other potential advantages of these medications. They're finding them in the liver, so they may assist with fatty liver. There's some thought about perhaps assisting with substance abuse issues, probably related to uptake in the brain, but these are things that are being studied now. So the way they work is they inhibit glucagon release. So in diabetes, the primary deficit is the insulin is either not as active as it should be or is absent. And so when we give patients insulin, it's to bring down their blood sugars. Glucagon is the counter-regulatory hormone and increases the blood sugar. And so it has a direct effect on the pancreas where it inhibits glucagon release. It also stimulates insulin release. So we're increasing insulin, we're decreasing glucagon. The effects on the stomach, it appears to slow gastric emptying. So I have patients describe to me that they feel fuller sooner and for longer. They normally would, have 3 pieces of pizza and then feel full, and now they have like a piece and a half of pizza and they're feeling more full. It also decreases appetite at the brain level, and this has been described to me by patients as kind of like less food noise, like they're not thinking about food as frequently, resulting in a decreased appetite. So there's also a GLP-1 GIP agonist, and this is a medication that stimulates the GIP receptor in addition to the GLP-1 receptor. So GIP is also made by the small intestine. There's also lots and lots and lots of other hormones that are made locally by the small intestine, and other compounds are currently being studied that include additional small intestine-produced agonists. But the one we have, which is the combination of the GIP and the GLP, is called Mounjaro, or tirzepatide, and it's the only one currently available. And Mounjaro is for type 2 diabetes. So the companies looked into these medications and subsequently had the data and research to approach the FDA of releasing these medications as weight loss medications. So the ones we have are Saxenda, which is the same active ingredient as Victoza, which is liraglutide. Remember, that's the one that you have to do once a day. Saxenda has been out for, don't quote me on it, but it's been out for more than 5 years. It works, but it's not as convenient, obviously, as being able to take a medication more than being able to take a medication once a week. So Wegovy is the same active ingredient as Ozempic, semaglutide. Zepbound is the same active ingredient as Mounjaro, tirzepatide. So when patients are talking about Ozempic, they're talking about the same thing that's in Wegovy. If they're talking about Zepbound, they're talking about the same active ingredient as in Mounjaro. But the difference is, obviously, they have a different name. It's to help with insurance approvals and for physicians to know why people are on medications, or at least assist in helping with why patients are on medications. They're packaged differently, and in the case of Wegovy, they actually have different dosages available. So as far as effectiveness, in general, and this is hard because there's not a ton of head-to-head studies, it's more kind of looking at degree of weight loss. But in general, and definitely not true specifically for patients, I've had patients have totally opposite results, but as in general in the studies, Zepbound is more effective than Wegovy, which is more effective than Saxenda. And we talked about Saxenda also being a once daily injection. So these are the Wegovy pens. So the doses of Wegovy are 0.25, 0.5, 1, 1.7, 2.4.
Basically, this is the medication present in there. This cap comes off, and there's a small needle and you can inject the medication. It's very easy to inject. The doses of Ozempic, as I said, are different. They're packaged differently. These Wegovy pens, you do it once and you throw it away. It's a one-time use pen, whereas the Wegovy pens, the Ozempic pens have an entire month's worth of doses in them. So there's one pen that either gives 0.25 or 0.5. There's a pen that gives 1 milligram doses, and there's a pen that gives 2 milligram doses. So those are the diabetes doses, as opposed to the weight loss doses. And it's basically, these are the doses they studied. Zepbound, there's actually 2 doses missing from this, but I couldn't find a picture with all of them. Same type of thing, the medication's in here. This cap comes off, the needle's there. You basically turn it from the locked to the unlocked position. You push in the plunger and administer the medication. They are also one-time usage pens, so you use them and you throw it away. The doses are the 2.5, 5, there's a 7.5 not shown in the picture, 10, there's a 12.5 not shown in the picture, and 15. So, actually I wanted to do this one first. So, effectiveness, right? So, I'm not going into all the studies, but pretty much these medications are effective. Are they as effective as we would like them to be or patients would like them to be? Not necessarily. There was a good review and meta-analysis, which was in Diabetes Care in February of this year, where they found actually mean weight reduction of 10.1 pounds. Now, I've seen patients who have lost no weight and in fact gained weight on GLP-1 agonists, but I also have multiple patients who have lost more than 50 pounds. I have a patient who's lost approximately 90 pounds. So it's quite variable who these medications work for, and then also it depends how overweight they are as to how much weight they will lose. The greatest treatment benefit appears to favor patients who are younger, female, without diabetes, with a higher baseline weight and body mass index, and treated for a long duration. So general treatment approach. So what they recommend is starting at the lowest dose, having patients do, and mostly I'm going to refer to the Wegovy and the Zepbound because those are the most common once-weekly medications. Plan to start at the lowest dose and have the patients do that once a week for 1 month, and then increase on a monthly basis following that. This is definitely where you see provider differences. So some providers will increase monthly as long as the patient's tolerating it without side effects, and we'll talk about side effects in a moment. They'll just continue to ramp up the dosage until the patient is pretty much maxed out or has a little issue with the doses, then they'll go back down. Other providers, and this is usually me, is I stop at an effective dose. So if I have a patient who goes up to, let's say, 7.5 of Zepbound, and they contact me and say, because usually what I have them do is contact me on a monthly basis, telling me, when they're ready to go up on the dosage. I tell them, if you're losing weight, great, on the lower dosage, just let me know, and we'll just continue on that. So I have that happen where a patient will be like, look, I'm losing 1 to 2 pounds a week on the 5 of the Zepbound. I really am noticing a decrease in appetite. I think I'd just like to stay there, which I am totally in agreement with. You also want to stop at a dose if you're concerned that a patient's not getting adequate intake. So with a decreased appetite, it certainly can decrease patient's thirst mechanism. So like if you have a patient who is going on a hiking trip, or you have a patient who has a job where they're working outside in the heat, you want to be careful about using these medications because they may not, it may affect their thirst mechanism and they can get dehydrated. In addition, you want to make sure that the patient is getting enough protein in their diet. Since they don't have a real strong appetite, you want to make sure they're just not eating, pasta and chicken nuggets or something, for example. All right, so issues with these medications, and I wrote potential and known because I'm going to talk about something that is basically my concerns about using these medications. All right, so side effects. So this is the big one. It really, because of how it works in slowing the gastric emptying, it can cause nausea, vomiting, abdominal pain. And this occurs more frequently the higher on the dosage you go. This is not necessary to lose weight. At the beginning, I would tell patients that this was a potential side effect when it was a diabetes medication, and they would come back to me, 3 months later and be like, oh my gosh, I'm in vomiting once a day, but my sugars are better, so I've just been continuing it. And I'm like, no, I don't want you to be feeling that way. This is a personal, professional thing. If I have a patient who is having a lot of side effects, even if it's working for their blood sugars or even if it's working for their weight loss, I tell them, you should stop it. This isn't for you. It's not worth it. A certain percentage of patients, interesting, some have diarrhea, some have constipation. So the diarrhea is a little more difficult to manage depending on severity. Sometimes patients have to stop the medication. With constipation, usually I just recommend using a half capful of Miralax daily, and then that usually takes care of that symptom so patients are able to continue the medication. There was just recently a article which was put out by Annals of Internal Medicine that suggested that they looked at a 2-year period from last year to 2 years prior for visits in the emergency department for complications from Ozempic and Wegovy. So Ozempic, Wegovy, same thing, both the semaglutide. This isn't the Zepbound. The Zepbound wasn't out at that point. And they suggest there were 25,000 visits to the ED in a 2-year period for these medications. There's some recent surveys that suggest that 1 in 8 Americans at this point is on or has tried this class of medication, maybe for diabetes, but possibly also for weight loss. And so that's a lot of visits. Now, I will say that doesn't mean that absolutely these 25,000 were definitely due to the medication. I've had patients call me and be like, I started having a GI illness. I think it might be my Wegovy. I say, okay, stop it. They're sick for a week. They say, okay, maybe I want to try the Wegovy again. I think, my son ended up getting sick, and it turned out it was just a gastroenteritis, but it could have been their medication. So more serious and infrequent complications, ileus, which is bowel obstruction, and these are the ones that were, this is why we tell patients to get checked out on the ER if they're having a lot of vomiting. The other one of which is severe and persistent gastroparesis. So this is stomach paralysis, where patients pretty much eat something and they just can't keep it down, or it makes them feel quite poorly. We did think until a while ago that when you stop the medication, your stomach went back to normal. But we've certainly seen cases where patients continue to have issues with this even after stopping the medication. The review I've done of that data looks like those patients had persistent symptoms while they were on the medication. And so a lot of persistent side effects while they were on the medication. So that's why I tell patients, if you're having persistent symptoms, this is not the medicine for you because it'll increase the risk of having that complication. The other thing is there is a black box warning on these medications for a possible increase in medullary thyroid cancer, which is a type of thyroid cancer. It's not the common one, but it's a type of thyroid cancer that in rats in high doses with this class of medication, they found increased incidence. What's hard is that this is a very rare thyroid cancer. I only have 2 patients in my practice, and you're going to have to treat many, many patients for many, many years to see if it actually does increase this specific type of thyroid cancer. So I talk with patients, do you have a history of thyroid cancer in your family, in yourself? Usually I know that. And what kind of thyroid cancer? Is there a genetic basis? Is there a syndrome, like an MEN syndrome, which is a genetic syndrome that presents with different endocrine conditions in the family? All right, so big one, insurance. So some insurances do not cover for any body mass index or health condition. So patient could be 600 pounds. They will not pay for it. It's just not on their formulary. It's not on their, it's a carve out of their insurance. Insurances that do cover, so generally do so for patients with a BMI of greater than 30, which meets clinical criteria for obesity, and a BMI either greater than 25 or greater than 27 with obesity-associated illness such as sleep apnea, diabetes, hypertension. Although I will say that a lot of times if you have someone whose BMI is greater than 27 and they have diabetes, you're gonna put them on one of the forms that's a diabetic medication because that 95% of the time will be covered for them. Just a little caveat, body mass index, it's kind of crappy. It's not a great measurement of overall health. It was determined many years ago in young white male soldiers, but unfortunately we don't have a great option other than like whole body CT scanning, looking at fat circumference, et cetera. So it's kind of what we have. So, you know, I take advantage of BMI when it's helpful to my patients, and I don't want to say ignore, but I pay less attention to it if it's detrimental to my patients. So if I have a patient whose BMI is 26 and they're like, I have to, you know, lose weight, I'm like, let's think about, you know, how your general overall health is. Do you have any conditions that are associated with obesity? How's your cholesterol, et cetera? Another issue with insurance is that insurances can change coverage. So even if you have the same insurance, come July, your insurance may no longer cover your medication. And so if you've been doing well on one, you have to kind of know that that's a possibility. They just announced that CVS Caremark starting in, which is a main provider of medication, that Zepbound is no longer first step. So patients who are on Zepbound have to be proven to not do well on Wegovy before the Zepbound's approved. Also, you know, if you change jobs and you change insurances, you may be on an insurance that does cover weight loss medications and go to one that does not. Most continue to cover long-term if weight loss isn't consistent or helping to maintain loss. So, so far, so good as far as insurances, that if they cover it, they're going to continue to cover it as long as you have lost some weight and that you're keeping it off or you're continuing to lose weight. For Medicare, this is a relatively new in the past year. They will cover it if the patient meets clinical criteria for obesity, which is a BMI greater than 30, and either documented coronary artery disease or obstructive sleep apnea, which unfortunately a lot of our Medicare patients have, but a lot do not, and therefore they cannot get the medications covered. So other options other than insurance is that both the Wegovy and Zepbound have manufacturer programs where you can get it directly from the manufacturer. You still do need a prescription from a provider. You can't just, you know, ask them for it. But it's still pretty darn expensive. Wegovy is about $499 per month, and Zepbound is between $349 and $499 per month, depending on what dosage. The other thing is that these medications, when you get it directly from the provider, from the manufacturer, come in a vial. And so you have to kind of measure out the amount of medication to give yourself, which of course leads to opportunity for errors in dosages. You could pay full price out of pocket, still need a prescription from a provider. I'm not sure I know too many people who are doing that, but pretty sure the celebrities who lose the 10 pounds for the red carpet, that's how they're getting their medication. You can get it through a weight loss program, such as Weight Watchers, but there's many out there. If you listen to any podcasts or spend any time on social media, you'll see them, hers, him, Weight Watchers, and a lot of these programs you can get it at decreased cost, at least for now. remains to be seen, like kind of what's going to happen long term. Because there were shortages of these medications, compounding pharmacies were given permission to make basically generic semaglutide and tirzepatide. And so compounded medications are out there. They're not FDA approved or monitored, so there's certainly concern about quality control or contaminated or unsafe ingredients. There can be more opportunity for errors on the part of the pharmacist or on the patient. I usually do not recommend this to my patients. Have I had some patients who have gone through compounding pharmacies? Yes, with providers from with prescriptions from other providers. I have not had anyone have any issues, but there are cases of people being harmed by the compounded medications because it's not as well regulated. There were shortages of Wegovy and Zepbound for quite some time, but there's no longer any shortages. So as of May 22nd of this year, it is illegal for compounding pharmacies to sell compounded semaglutide or tirzepatide injectable drugs. Now, that being said, like I don't think anybody's been sued for providing them at this point. We're only, how many weeks in? I know that they will allow it for cases where the regular dosage would not be appropriate. So I guess people could make cases that, like tirzepatide, 7.5 milligrams didn't work, and 10 made me sick, but 9 milligrams a week I'm great with, and so I need to get it through a compounding pharmacy. So there are kind of ways. I had a patient tell me as well, I did not go into the dark bowels of the internet to discover this, but she was telling me that she's seen things that are basically like, well, we're also going to put other things in with the medication so we can provide them. So B12 probably wouldn't be a great example because that's an IM injection. These medications are sub-Q, but we're going to put some type of vitamin in with your tirzepatide, so therefore it is not covered by this law that makes these not able to be made as of May 22nd. But the other way is that if you're getting through a weight loss program, it isn't necessarily a compounded medication. What these companies will also do is just buy a whole bunch from the manufacturer and then kind of batch it and distribute it, so they're able to get it at a discounted price. Compounded pharmacies are not allowed, and these programs are not allowed to say you're getting Wegovy if you're not actually getting Wegovy, or getting Zepbound if you're not actually getting Zepbound. They have to say the generic preparation. So one thing that I talk about with my patients is that they probably need these medicines long term. So a lot of patients are a lot less likely to go on them if they realize, like, I'm going to be on this for a long time. And this is because obesity is a chronic disease. So treatment with these medications also frequently needs to be long term. Do I have patients who have lost weight with these medicines and been able to get off of them? I have, and they've been able to maintain weight loss, but usually that's in specific instances, like I need my knee replaced, but they won't replace it unless I lose, 30 pounds, but I can't be active, so they go on the weight loss medicine. They lose weight, they get their surgery, they feel better, they're walking more, their general health is better, and they're able to keep the weight off. But patients should be aware of this. I make sure that patients are. It can be challenging, as we were discussing, with changing insurance plans. Also for women, you cannot use these medications during pregnancy, so they would have to go off medication during pregnancy. We talked about this briefly. Patients who are obese or overweight can become malnourished. So you really have to make sure that their oral intake is reasonable and that they're getting enough protein in their diet. And you have to make sure that their thirst mechanism remains intact. So I'm going to post or submit this presentation to go on the website, except for this one, because this is just me being me. I have concerns about this class of medication. I use it a lot. It's a wonderful class of medication. But I have seen cases where it's being inappropriately used for few pound weight loss, for specific events. I don't like how it may change our societal beauty standards back to, heroin chic of the 1990s, which was what it was when I was a teenager. I don't want it to be making physicians or general community less accepting of larger body types, because people are like, oh, they could just go on this medication and we wouldn't have to deal with it. There's a question about possibly an increase in eating disorders. We haven't seen this yet, but if you're influencing societal beauty standards, that may follow. And also more of just kind of a change in societal expectations. The expectation for patients who maybe are quite comfortable in their body, and that's between themselves and their doctor to discuss what they want to do with their health. And I don't want any, societal pressures for them to do something that they're not interested in. So those are kind of just my personal thoughts. But once again, I have lots of patients who have been on this medicine. These medicines, I have had certainly patients who have had side effects. It's not for them. I've had patients who have had great success with it. I've told patients, no, I'm not going to prescribe that for you because I think, I know you don't like that 5 pounds on the beach, but it's fine. Your BMI does not make it appropriate. Class, and of course, the beginning, this class of medication was first started for diabetes, and it was the thing that has changed diabetes management probably the most in the past 20 years. So wonderful medication for diabetes. There's a lot of research, as I stated, into other conditions that this may assist with, substance abuse, fatty liver. These medications are approved for type 2 diabetics, but there's some suggestion that used early in type 1 diabetes, when patients are in the honeymoon phase, that they may prevent progression of diabetes. So there's lots of information to be gleaned from this class. So, questions?
I have one. Or go ahead.
Oh, go ahead.
Do you think that these medications are going to be sort of extended for alcohol abuse, substance abuse, other sort of?
Yes, so that's definitely the areas that they're looking into now. However, there is some concern about maybe increasing psychiatric symptoms after being started on the medication. So it does appear like kind of long-term, it may assist with kind of substance abuse, brain disorders. Theoretically, I can think, well, maybe if someone's losing weight and they, think that this is going to make their life better and it doesn't, that it may cause some depression or other issues. So that is something that they're following up with in post-surveillance studies.
And I think so far they have not actually shown anything definitively. At the beginning, there was some real concern about depression and also suicidal ideation, but so far nothing's really come to fruition in the research from what I've seen.
Thanks, Lee.
They are, which is great.
Thank you, Lee.
I think that's what I was actually concerned about, because the adolescent population is very interested in this drug. And I have similar concerns as, do we make it that easy for certainly the whole class of people cannot even entertain this drug because of the price. But does it make it easy to ignore the value of food and exercise in our society? I do think it has societal changes. I have seen, because we have to always be looking at suicidal ideation. We know that GLP receptors are in the hypothalamus, and we know that the free dopamine falls. So we are always looking at depression, but we get lots of questions about this drug. And typically, I will send my own patients to endocrinology for this. You guys are the specialist.
I'm happy I do not see any adolescents because I would have trouble deciding if I would prescribe this medication to them. Yes, Seth?
I have a follow-up comment and a question for you. In my experience as a PCP, even when the payers do cover these, they require documentation of a pretty stringent course of lifestyle optimization, supervised weight loss, exercise program, to emphasize the importance of those first. And I don't know, how closely people are adhering to those things when they say that those things have happened, but the payers require documentation of those things. We've also seen payers rescinding coverage, sort of like you alluded to, including some prominent local payers really becoming quite strict about the coverage of these medications in the last year. A question that I have that I have not understood is why the GLPs need to be complex with the GIPs, like in Mounjaro.
So it does, so the way I think of it, and once again, this is me as a physician, is that probably in some individuals, some of those peptides are more important than others. So maybe in me, the GIP is more involved in my brain signaling for appetite, and maybe in someone else, the GLP. So I've certainly had patients who have tried Ozempic, Wegovy, and have not lost weight, or have lost, 2-3 pounds. And then they go on Zepbound and Mounjaro, and they have lost significant amount of weight. I have had patients who, cannot tolerate Mounjaro as far as side effects, who can tolerate Mounjaro Zepbound side effects, but can tolerate Ozempic Wegovy. So, in theory, and in practice, usually the Zepbound and Mounjaro is better tolerated, probably because it's hitting those two different peptides at a lower level versus one peptide at a higher level. But I certainly have patients who totally knock that down, and they from the first dose of Mounjaro, they felt horrible, and they're on the highest dose of the Wegovy, and they're fine on it. So they're also looking at, there's one that's like a 3 in studies right now. I think it's, I forget the name of it, but they're doing research where they're looking at 3 different peptides. So I think we're going to continue to find these peptides, and then the question's going to be, perfect world, right? We do a blood test, and we'd be like, oh, George, your most important peptide is the GDP. I'm making that up. The GDP, and then, there's a medicine specifically for GDP, but we're not.
Just to clarify, though, tirzepatide is not 2 compounds. It's a dual agonist. It acts at both receptors.
Yes, that's correct.
And then the most recent, the third one was a Regeneron phase 2 study was published with I don't even know which receptor, where they were in it for sparing of lean muscle mass loss that accompanies, especially in older folks, the weight loss accompanying these drugs.
Yeah, so that's something I didn't say in side effects, complications, because once again, I could do a 4-hour talk. But yeah, there's some concern that patients are losing muscle mass in addition to fat mass, and that we may actually be, increasing their capacity for falls and breaks and et cetera.
But does that accompany bone density loss? I don't know.
Hasn't been well studied. So, it would make sense, right? People who have a higher body mass index tend to have better bone density. And you can imagine if your appetite's low and your least favorite food is milk products, you're going to be getting less calcium and vitamin D in your diet anyway.
So with regard to social ills, when I started in the game of diabetes, there were no injection pens. You drew it all up by syringe and gave it to yourself, and there has been a dramatic improvement in the accuracy of injections, where unit by unit really does count with insulin dosage. But if you say that, you said as many as 1 in 8, if 1 in 50 Americans is taking a drug 50 times a year, there are billions and billions of disposable medical waste products ending up in the landfill. And it might be a social value to go back to drawing it up with syringe and giving, especially when the exact number of units is less critical than it is for, say, a product like insulin, right?
Yeah. Or even, a pen that you at least use for a month, right? So you would create 1/4 as much waste as doing it weekly.
Do you see oral dosing coming down the pike at all?
So there actually is a semaglutide which is available, which is oral, which is Rybelsus, which is only used for diabetes at present. It does not have a weight loss equivalent. I have had some patients lose weight on it. That's being researched now. Yes.
One other comment I'll make is that there are people, please give me feedback on this comment, but I believe there are people for whom, their degree of weight loss that's indicated is not, it's not appropriate for them to take the medicine. They should be directed, or they should consider strongly bariatric surgery if they have severe levels of obesity, if the amount of weight loss that's going to be achieved with the medication is not going to be enough to address the reasons why they need to lose weight, then those individuals should at least be considering bariatric surgery. But unfortunately, a lot of people who should be considering bariatric surgery are now not interested, they're not considering it because obviously, most people would be more interested in a medication than having a surgery.
So there are programs, for example, Jefferson employees, so I'm a Jefferson employee, Jefferson employees who have been on these medications have been able to get them through their primary care. They're now requiring those patients to go to a weight loss management clinic in Bala Cynwyd, and that may be a system setup that we're seeing in the future because those programs look at other options, opportunities. They have a bariatric surgeon on staff that could come in and speak. So certainly, and there are, I'm talking about these. I mean, there's a few other oral weight loss medications. The reason I'm not talking about them is because they're not as effective as this class. So yeah, there are those kind of opportunities as well. And I will say, yes, insurances with lifestyle. I mean, basically, you just have to check a box and say the patient has tried lifestyle modifications. Now, what do you require the patient to do to check that box? Go to a nutritionist. It's debatable. Go to a nutritionist. Talk about it with you 4 visits in a row. Every patient that I talk to will be like, "Oh yes, I have tried diet and exercise," and I'm sure some have, but I'm sure some haven't. So,
Lisa, could I ask you
Sure.
To just speak more on the rebound for the weight part of this? I mean, it's a great drug for diabetes, a real need for that. And we're looking at the risk benefit for weight loss. Do you have patients that have had to be off of it for one reason or another?
Yes.
And that they have, do you see that as a trend, or what does that look like?
I would say that the trend now is to keep patients on it. 5 years, well, I shouldn't say 5 years ago. 2 years ago, we didn't know if patients would regain this weight. And as time has gone on, it's basically been shown. Now, it may not come back, and the other question is, well, the answer is probably no, because we don't want people's weight yo-yoing. But how about, so maybe somebody loses that 20 pounds, gets them feeling good, more active, they go off of the medication, and maybe they regain that weight, but maybe they do it over the course of 2 years. Well, have we gotten benefit for them in the 2 years that they were at the decreased weight? Perhaps. Should we restart it at that point? Perhaps. It's just tough because long term we don't know kind of what benefit is.
Thank you.
Okay, cool. All right. I will leave here and I'll be back there.
Thanks,
That was
fantastic.
great. Thank you.
Alrighty, so next on the agenda, we had old business with no particular business listed. New business, Jenny, our school liaison, was not able to be here this evening. So that brings us to Maggie from the Board of Commissioners.
Yeah, I don't have much for you. Again, we've been pretty involved with land development and haven't really had any public health issues other than the dog thing I mentioned. That will be up next Monday for the stamp, assuming we vote for it. And that simply, as I stated, says that dogs in Radnor parks that allow dogs will need to be on leash, with the exception of the 2 dog parks and Skunk Hollow, because it has its own ordinance. And as someone will mention under public participation, I'm sure, summer is coming. So I did see, I was in the senior center the other day during the music festival, checking out the police command center, which was very cool, that they have a huge stockpile of fans. So just to put that out there, not that fans are the be-all, end-all, but they're better than nothing.
Great, thank you, Maggie. County update I kind of did earlier. Last thing on the new business is Lee and I had discussed after last meeting, maybe planning for next year. If anyone thinks it would be a good idea to kind of send out survey, if anyone on the board is interested in speaking on a specific topic, and you can, make it 6 months down the line if you don't want to do it the day of your presentation like I did. You can plan way ahead of time. And also kind of looking at maybe other topics that you think the public could use hearing about, and if you have anybody that would be able to speak. So just some thoughts for the summer. In addition, we'll be going and obtaining our interns in the fall. So if anyone is interested in being a mentor for the interns, keep that in mind, and we'll be back in a few months. Okay, public participation. Any members of the public wish to speak?
Hi. My name and address. Okay, my name is Jillian Norris Santo, address 424 Inverary Road in Villanova. And my comment, it's brief, but my comment today concerns the diesel buses that Villanova will use. I would like to ask the Board of Health to determine the following. How will the air quality in Radnor Township be affected by Villanova University's use of the diesel-fueled buses on its campuses? Will some of the daily bus routes include travel on public streets as distinct from the campus? For example, on streets near the high school or Radnor Elementary School or any other township street, such as perhaps County Line Road or any other roads. I don't know what that would be. And as you know, the prevalence of air pollution is an ongoing health issue in Delaware County and in Radnor Township, essentially everywhere, what with the addition of wildfires to the mix that we often have to deal with. And so I believe we need to know the volume of the emissions from these buses and the chemical makeup. It's not hard to determine, I'm sure, if the emissions are analyzed. To date, I think, and I'm speaking for myself and many others, we have only hearsay about how often these buses will run, for how long, and where. We can't estimate the amount of admissions that we will need to deal with, and we need exact routes and frequency. I understand that Villanova completed a traffic study or studies in connection with university projects, particularly the new Welcome Center. That was a recent project. I attended the zoning board meeting, and they mentioned these studies. The study was given to the zoning board, but it was not made public. It wasn't projected, and it wasn't discussed during the zoning board presentation. I'm referring to a traffic study. How can I, as a member of the public, view that report? It may contain some information about the buses, routes, and emissions. So to conclude, I hope that the Board of Health will bring these concerns to the Board of Commissioners, and that you will develop a report for the community on the emissions to be expected from the diesel buses, because it's a matter of grave concern. I don't need to tell you, you're all in science and health, a matter of grave concern to everyone, and especially it's of concern where children are concerned because their lungs are so rapidly developing with every breath they take. So thank you.
Thank you.
Sarah Pilling, 29 Garrett Avenue with a slight detour. There will be 2 routes to and from Cabrini to Villanova, and they will go at 15-minute intervals each route between 6:30 in the morning and 10:30 at night. That's what Villanova told us. So I have a sidebar and then a comment. The injections, they shouldn't go in the landfill, and they certainly cannot go in the recycling because they have a needle attached to them, so it's not allowed. I have an issue that just came up for me last week that I don't have any real information on, but I think you ought to know. I've had a respiratory whatever since Christmas, and last week I finally went to the doctor, and he put me on a cough medicine, or he wrote a prescription for a cough medicine that had a low dose of codeine in it. Neither Rite Aid nor CVS handle any controlled substances. My doctor didn't know this. He was a bit shocked. The other thing I want to say is I got an MMR vaccine at my elderly age. Well, it was 10 years ago, because I had all those diseases as a child. Man, was I sick. I had to come home from Haiti, which is where I got it, because the Army was there and they were injecting little kids, and they said to me, "Why don't you get it?" So anyhow, what I've come to do, and I feel like either a curmudgeon or Don Quixote, is to once again speak about heat for infants, toddlers, the immunocompromised, and seniors. Dr. David and Maggie were very generous, they read JAMA, I don't, to send me the recent article about the research. And once again, the heat is terrible, but where it's most effective is when the nighttime temperature does not drop below 85 degrees. We are projected to have between 30 and 32 days of over 90 degrees this summer. What we need is cooling sessions, partnerships with churches, community centers. It's not a big deal. So I ask you to once again, one more time, request sincerely that the Board of Commissioners and the Township looks at how there could be some opportunities for some cooling centers. If you're cooled down by 10 o'clock, you're in good shape. I have personally experienced this. I would not ask for it. I live in a funny little old house built in 1920 in Garrett Hill. The infrastructure is not acceptable for air conditioning. I tried it for 2 summers. I was really in trouble. So I had to spend $17,000 from my savings to put in a heat pump and mini splits so I could have cool temperature in my kitchen and in my bedroom. This is not fun. Thank you.
Thank you, Sarah. Any other public comment or any comments from the board? All right, excellent. Motion to adjourn the meeting? Second?
Second.
All right, adjourn the meeting of the board until September.